Hello, my name is Nicole Gee, and this is an introduction to the clinical nurse leader role with Professor Mary Straley at the University of San Francisco. This is the culmination experience. Over these last months, I've come to understand more about what it is to be a master's prepared nurse and to scratch the surface in comprehension of the potential in the clinical nurse leader role as a way to address quality of care, patient outcomes, costs, and to meet society's medical needs. The formal and advanced education availed through the University of San Francisco seeks to take the nurse and transform that person into a critically thinking, outcomes-focused clinician with the aptitude to anticipate, evaluate, and implement best practice models through leadership and interdisciplinary collaboration, all under the umbrella of social responsibility. The following represent 5 key issues observed in the clinical setting through clinical nurse leader colored glasses, with an elaboration on one of these issues. There will also be a few thoughts on concerns likely to move forward in the coming courses. The first key issue pertains to ambulatory adult oncology and hematology patients. As the facility and staff have no current position or understanding of the role of the clinical nurse leader to improve standards and policies that impact patient care, the infusion nurse is removed from understanding, educating, ordering, and management of oral chemotherapeutic agents and focuses solely on infusion medications. The nurses are responsible for triaging calls and symptom management that may involve unfamiliar medications. This concern is suitable for the clinical nurse leader. However, there is not currently a position available, or do management or medical staff have an understanding of the clinical nurse leader role. The CNL, however, would advocate effecting change through advocacy for the profession, interdisciplinary healthcare team, and the client. The CNL also works as a clinician, assimilates and applies research-based information to design, implement, and evaluate patient plans of care. Our second issue also pertains to ambulatory adult oncology and hematology patients. Currently, there's no mentoring nurses or promoting care policies and practices, participating in their development, or providing leadership and implementation and evaluation of guidelines, professional standards. In other words, there's no training or retention strategy. The organization has a limited professional development model, poor communication practices, outsourced human resource services, and an informal orientation program. This provides for a low incentive environment, no room for growth, and no solid push for continued education. There's a lack in recruitment, retention, and investment in the talent they have available. The clinical nurse leader, however, approaches this issue with an understanding of cost outcomes that improve safety, effectiveness, timeliness, and efficiency of quality, and to the degree that they are client-centered. The CNL also acts as an educator using appropriate teaching and learning principles and strategies, as well as current information, materials, and technologies to facilitate learning of clients, groups, but also of other healthcare professionals. Our third issue pertains to adult care patients in care transitions. Organizations must continually look to best practice and be willing to adopt new ideas while keeping the patient as the focal point of care in order to increase patient safety and reduce unnecessary rehospitalizations. This issue pertains to how and what kind of care patients experience as they are discharged from the acute care setting. Hospitals, including Marin General Hospital, fall miserably short with post-discharge medication issues, confirming follow-up appointments with care providers, and even ensuring patients have adequate support wherever they're going after the acute care setting. This lack in aftercare has contributed to costly and unnecessary emergency room visits and hospital readmissions, in addition to confusion and danger for the patient. The clinical nurse leader, however, assumes accountability for healthcare outcomes for this specific group, recognizing the influence of the meso and macro systems on the microsystems. The clinician also assimilates and applies research-based information to design, implement, and evaluate client plans of care. As an outcomes manager, synthesizes data, information, and knowledge to evaluate and achieve optimal client care environment outcomes. Our fourth issue pertains to decreased momentum for program implementation. A communication and shared information at the microsystem are mainstays in excellent patient care. However, due to organizational barriers such as high turnover, a delay in policy adoption, limited accountability among staff, as well as the distraction of computerized physician order entry at Marin General Hospital, the communication program is not currently fully implemented. With the help of a clinical nurse leader as an information manager, she would use the information systems and technology at the point of care to improve healthcare outcomes, and as an educator, use appropriate teaching and learning principles as well as strategy and current information, materials, and technologies to facilitate the learning of clients, groups, but also of the healthcare professionals. Our fifth key issue applies to the adult inpatient population and discrepancies in discharge medication reconciliations. Effective patient safety from hospital admission through complete discharge requires the strategic planning, education, and effort by all staff to minimize system errors. Discrepancies in discharge medication reconciliation reports when transitioning from acute care to other care facilities or to home is of great concern for patient safety. Marin General Hospital's administration is concerned as the facility discovered that of the patients readmitted within 30 days, less than 20% had accurate discharge medication reconciliations. The clinical nurse leader would act as a systems analyst and risk anticipator, participating in systems review to critically evaluate and anticipate risks to client safety and improve quality of client care delivery. As an outcomes manager, synthesizing data, information, and knowledge to evaluate and achieve optimal client care and environment outcomes. SMART goals for the clinical nurse leader to address include specific measures, accurate discharge medication reconciliations. These are measurable through the chart review process. This is achievable through the use of electronic medlist comparison, through involvement of the pharmacy department upon admission, and improving the nurse involvement in teaching prior to discharge, utilizing communication technology. This is relevant due to the impact on patient safety and the cost associated with unnecessary readmissions and mishaps. This could also be time-bound by auditing charts on a monthly basis, creating meaningful reports. A full process streamlined in 12 months is realistic. The concerns of safely transitioning patients out of the acute care setting, ensuring accurate medication reconciliation with each patient, and staff retention are all issues that require continual reinforcement, and it is within the clinical nurse leader's scope of practice to analyze and implement effective strategies to ameliorate these issues. Thank you very much.